Good morning. Before we get started today, I just wanted to go over just a quick housekeeping announcement. We want to really encourage everyone that's faculty and especially trainees to join us for our CME event in the Department of Psychiatry. It's going to happen on Saturday, April 6th here in the auditorium, and that'll be from 8 to 3:30. I guarantee you it is worth a Saturday. They'll be covering a number of really important issues, and it's really looking at treatment issues related to maternal health, substance abuse, and also DBT and its application across different modalities and spaces, whether that's in day units or different age groups and so forth. Again, so April 6th, please mark your calendars. You should have received an email on your Columbia account, and we would really encourage you, please register. It helps us get a head count and to prepare for the day. We guarantee it'll be a wonderful time with faculty, and again, please strongly encourage your trainees across each discipline to attend. With that, it's my pleasure to introduce our Viola Bernard speaker this year, Dr. Guy Diamond. Due to the generous support and endowment through the Viola Bernard Foundation, our Department of Psychiatry and the Division of Child and Adolescent Psychiatry continues the vision of Viola Bernard. Dr. Bernard had an enduring commitment to social justice and to disadvantaged children. And within her field, she really worked to focus on social psychology. Her affinity was focused towards programs designed to assist disadvantaged families in assessing services, improvements to adoptive and foster care services, and effective evidence-based psychosocial services and policies. So far, throughout the Viola Bernard Endowment, our division and departments have benefited from training in PCIT, Parent-Child Interaction Therapy, AFCPT, Alternatives for Family CBT, involving trauma treatments, IPT, interpersonal psychotherapy, DBT, dialectical behavior therapy, and even more so, moving that into the schools, DBT Steps A. The big piece too here throughout the department through the Viola Bernard has been to equip our community. And so we've been really excited to have our community-based organizations join us, places like FYI, the Joe Torre Safer Homes. We really want to be able to be an institution that works towards looking at the most effective and evidence-based care to really treat our community, but also to empower our other partners throughout our community to provide the most effective care. And with that being said, I'm delighted to introduce Dr. Guy Diamond. He's the Associate Professor in the College of Nursing and Health Professions at Drexel University. He serves as Director at the Center of Family Intervention Science. He is the primary developer of attachment-based family therapy for depression and suicidal youth. Attachment-based family therapy has been rigorously tested in several clinical trials and process research studies. With that, it enjoys the distinction of being an empirically supported treatment in SAMHSA's National Registry of Evidence-Based Programs and Practices website. Additionally, Dr. Diamond has focused his research on youth suicide prevention and treatment research. In particular, that really aligns so much with what we do in the clinical services in equipping primary care physicians, also working across how to look at equipping different non-mental health providers to really close the loop on making sure that we're all treating suicide and looking out for that as a whole entire community. It is my delight to introduce you to Dr. Guy Diamond.
Thanks. Okay. Well, welcome. Thanks for coming out for your lunch break. Hope this can be an interesting, informative conversation. How many people are child-focused providers? Okay. Oh, good. I'm speaking to the choir then. So I'm assuming a portion of your time is working with parents and trying to rally them in some way or another. So that's helpful. So this will map onto your interests and well. Let me start with my disclosures. I'm definitely have been funded by NIH a couple of times for studies. We also have a book for sale, and we do a lot of training around the country and get royalties for that. I don't drive a Porsche based on any of that work, but that's what us academics do, you know. I'm going to start a little broad. I gave a talk this morning. Those of you that came, some of this will be reiterating, but I wanted to talk a little bit about how attachment theory can inform the goals of therapy, particularly family therapy. The core premise of attachment theory is that parents provide a secure base for children, that it's through their emotional responsiveness, availability, sensitivity, that kids tend to develop a more internalized sense that the world is a safe place and that I am worthy of being protected and taken care of. So attachment theory is really a model of how relational experience influences one's internal perceptions of self and other, and that those internal working models or schemas then influence how I behave in the world. And for Bowlby, it's a transactional model of constantly interchange between experience and internal working. For attachment theory also thinks a lot about emotion regulation. And when kids live in a more secure-based environment, they're more likely to turn to their parents for help. The kid who falls off his bike and scrapes his knee instinctually jumps up, runs to his mom up on the stoop, gets comforted, down-regulates his fear or anxiety, and slithers back off the lap and goes back to play. And kids know that parents will provide that kind of security when my anxiety elevates. For Bowlby, attachment is really a process of protection. It's not about love, as is often sort of bastardized in our pop culture, that it's, and with adults, there's a little more mutuality, but for kids, the attachment system gets activated when the saber-toothed tiger is outside the cave, and I'm running inside to get protected. But kids also, when they feel safe, when they feel they can go for comfort, they also feel more able to express and talk about what they're feeling, to put into words their fears and anxieties. And in doing that, they learn how to tolerate and how to express their own emotional experience. And what we know from emotion theory and emotional processing and psychotherapy is that emotions are a vital source of information about who we are, what we need, what we feel, and that those, how we access our emotions impacts how we behave in the world. And the more we're able to be self-appraising of the kind of emotional needs we have, the more able we are to act in the world in a way that's going to get those needs met. So if I'm someone who is angry is sad, I feel rejected and abandoned by my parents, but I act angry all the time, that expression of anger never gets my sadness, my internal vulnerable feelings met. I keep responding with anger, and I keep, in fact, pushing people away, when in fact what I really want is someone to pick me up and take care of me. And people in secure relationships feel more comfortable accessing, expressing those more vulnerable emotions, and that's why we think about that as an important element in family life and family relationships. Adolescence attachment is just as critical a phase of life, the important process. Kids are not looking to separate and individuate and run away from unless the experience in that family has been negative. That the inherent drive for most kids is to remain attached while developing autonomy. And that is the central task of adolescence, how to transform my closeness to my parents. I don't need them to change my diaper anymore or, get me to school on time, but I need them to be there for me and trust me and, someone I can rely on. But I also need to have the independence to go out at night and do more things and build peer relationships and fall in love, and the capacity to stay connected while developing independence is the core developmental task of adolescence. And any of you that work with families often find parents struggling with that balance. They're too controlling, too involved, too abandoning, too neglecting. And really what we want to try to recreate is a sense of a secure base in parents that provides little kids, they fall off their bike, they run to mom, they get soothed and calmed down. Teenagers do the same. They don't come to parents for everything. They start to have a peer group, a love group. But when we do a study called, what is that study? Critical events. We give kids a list of things that might have happened to them and who would they turn to for help. So I break up with a boyfriend, I go to my girlfriend, I go to a friend. I get in a car accident, I call my parents. That there's still a hierarchy of relationships. And when more critical events happen for adolescents in healthy, normative attachment relationships, kids still turn to their parents. Some of us still turn to our parents. How many of us still, oh, I got a new job, I'm calling dad, I'm gonna tell him, we got a new car, I want him to know. Grandma's sick, I better tell, there's still a kind of tendency to want to reach out and have some link with the people, or wish we could if we don't. So attachment has a kind of lifelong structure. It changes, it transforms, but for us in adolescence, it's a vital part of development and a critical part of the clinical conversation. Because a lot of parents either have given up and abandoned their kids or are over-controlling and still treat them like they're 12 years olds. And we're trying to help them recalibrate to get in a more normative spot so the kid has a best chance at moving forward. Why is a secure base important? We know that there's tons of research to suggest insecure attachment, high conflict, low cohesion, these kids are more at risk for depression and suicide. Constantly, every study, the more severe kids, more family conflict, less cohesion. So we know this is at least a risk factor. Sometimes conflicts in families cause kids to feel suicidal. The divorce, the domestic violence, the over-controlling parent. I mean, these things, our kids come in and, 80% of our kids attribute at least some of their suicidal feelings to conflicts with my parents. They don't understand me, they're over-controlling, they don't like me, some version of their suicide narrative incorporates family drama. But not all suicidal kids are driven by family conflict, and a lot of kids have stressors from other places. School failure, being bullied. We work with a lot of gay and lesbian kids who are being discriminated against, but they can't turn to their parents for help. Parents are unavailable. The gay kids, their parents are ambivalent at best and rejecting at worst. So they don't have that natural attachment context to turn to for comfort, for safety, for protection. It's not that the secure base is going to solve everything. Kids come with temperament, kids come with biological vulnerabilities. There's a lot going on. But for us, if I can rally the family, the secure base of the family, it gives me, I say this to my families in a number of ways, but it gives me the team. It makes us a working unit so we can then solve other problems. That's how I kind of sell it to the families, to the parents. I need you on my team. I can't solve these school problems on my own. I can't get your kid back to school. But if we could work through some of the things that get in the way of your kid trusting you, and he could rely on you more, then as a team, we could kind of get to work to solve some behavioral developmental problems. What is a core assumption of ABFT, the attachment-based family therapy that we do? We are looking to improve family organization, warmth, and trust so that, as I said, families can serve as the normative developmental context for adolescent life. A lot of families come to us and they're just out of whack for a variety of reasons. And my job is, can I reestablish some normal family functioning so that I have a secure base from which to move this kid forward? We also believe that in vivo experiences, in-session conversations, are a more potent interaction and change mechanism than me talking with kids by myself. That's got to be tested, and in fact, some of our data challenges some of that, you'll see. But we believe, how many people have seen Good Will Hunting? Everybody's seen Good Will Hunting, right? Who wouldn't want to be in therapy with Robin Williams, right? He's like fantastic, and anybody would grow and change. But it took him a year to get to the point where he could say to the kid, it's not your fault. Remember the big scene at the end? It's not your fault. And what is he doing? He's knocking at the door of this boy's attachment narrative, this schema about himself. My dad beat me and I deserved it. I'm a worthless, no good kid, and the only thing I should do is be a janitor. Kids internalize this self-hatred, this low self-worth based on the relational experience. And here, Robin's knocking on that door saying, you can take this mask off. It's wrong. It's not your fault. It wasn't your fault. Your father was beating you. And finally, the kid has an epiphany in this, finally a breakthrough of a deep emotional embrace of, oh my God, it wasn't my fault. It was him, and I don't deserve to be treated this way. And that sort of psychological moment frees him up to drive to Stanford and follow his love, right? Which we'd all want to do also, I'm sure. For us, we want the father to come in the room and say that. We believe there's a potency that if the father says, and this isn't while the abuse is going on, we're not talking about bringing in abusive parents or sexually abusing fathers, this is 10 years later. I want the father to come in and say, it wasn't your fault. It was me. I was a drunk. Your mom left us. I was depressed. I never should have done those things to you. Maybe he apologizes, but the goal is a kind of validation, and taking back the kid's false narrative about his explanation of events and helping the kid have a more informed, balanced view of what happened in life. And our assumption is that if the parent, I can validate all I want for years and years, and it'll never add up to what it would mean if the father said it. That's, it's still a question up for, actually, we've done some studies to look at it. I'll talk to you about that. Not only does this conversation with the father in the room validate this trauma story, but the very act of the parent being in the room, being available for the kid, saying, tell me how bad it was. I'm willing to sit here and let you be mad at me, enacts a corrective attachment experience. Because attachment is kids are hurting and parents are supporting. I hurt my knee, I tell you about it. I lose my girlfriend, I tell you about it. I hate you all my life because you were a drunken alcoholic, and I finally get to say it to you. And you don't scold me, you don't defend yourself, you don't criticize me, you say, you're right. I let you down. So in the room, we're giving them an experience of secure base attachment. Again, hoping that technology, if you will better penetrate one's psychic schema than my validation and empathy. How do we think about the core mechanisms of change? We are definitely interested in the intrapsychic world of not only the kids, but the parents. We believe that we have to get to these narratives, to these schemas, try to understand them, how to get to more primary emotion so that they can understand how hurt, in fact, they were. You know, most of our kids come in, you must be pretty upset about your parents' divorce. I don't care. They do their thing, I do. And that's not where they live. That is not what when they're at home and mom and dad are downstairs screaming and they were 8 years old, they weren't indifferent. They were terrified. My world is falling apart. And nobody took care of me because they were so preoccupied with their own hostility towards each other. We need to get to those stories. We think they lie at the core of kids' suicide. A lot of our kids, they're driving their suicide. I hate myself. I'm a worthless kid. I don't deserve to live. Now new problems are coming up. I have no capacity to solve them because my emotional inner world is so bound up and dysregulated. The global distress is overwhelming. I might as well kill myself. But at the same time, we are interested in targeting the interaction between people. How do people talk to each other? How do people listen? Do they validate? Can they be patient? Can the parent beam on the kid? Can the parent be available for the kid like they should have been when the kid was 8? So in ABFT and in family therapy, unfortunately, it's been a lot of focus on the interaction. I'll admit, it's my family, I can criticize them, don't you dare, I'm kidding. But family therapy has become a more behaviorally oriented model, move some chairs around, focus on parental structure and hierarchy, get them to solve some problems. And I get lumped with the psychoanalytic family therapy now because I'm interested in the inner world of people. But I'm interested in how the inner world is interacting with the interactional world and how the interactional world is shaping the inner world. And for us, we feel like unless I'm attending to both of these domains, I'm not going to get progress in my treatment. What's some unique things, and started to say, I think bringing, attachment theory is the rage all over, everyone's doing attachment theory. I started it, no, I'm kidding. There's a bunch of adult individual therapy models using it. Schema therapy uses it. Dan Hughes uses it. Everybody's using it to help describe the therapy process. It's quite in vogue. But the family therapy world is still sort of stuck with general systems theory and narrative therapy models. So it's in the family world, it's a little bit more unique. I think we also, from an attachment lens, we are not behavior management therapists. We actually avoid and block it in the beginning of treatment and say, look, behavior management is all about a power struggle. And until you guys become more of a team and trust each other, and your kid feels like the things you're doing for his well-being rather than to control and annihilate him, we're never going to solve the behavior problems. And in fact, behavior problems for a dysregulated kid become the vehicle for expressing anger about more interpersonal problems. That's how we frame it, we say that. Win parents over on that. Another thing we've done is we have brought some structure to family therapy. Family therapy can be a pretty unwieldy activity because you got so many people in the room and so many agendas in the room. And am I doing behavior management? Am I dealing with mom's depression? there's so much anger, there's so much resentment, the parents aren't working together. I mean, it's a complex landscape. Give me individual therapy, it's a lot easier, right? Unless you love a little chaos, like some of us. But family therapy has always been a little vague. It's not very well laid out. It's not structured well. And we have tried to bring a scaffold to it. Goals, outcomes, we call it task that we work on. Things, very clear, step-by-step approach, but still trauma-focused, emotion-informed. The self of the therapist is critical in our work. This is a very intense, personal kind of therapy. It is not a worksheet, go home, do some homework kind of work. So if you like that, anybody wants to leave now, it's fine. No, I'm kidding. Mnuchin used to say, family therapy is like being an aunt or an uncle. Close enough that you care, but distant enough that you go home at night. And this is a very intimate therapy. So it's a lot about you as a therapist and your capacity to get close to people, to challenge people, to guide them to places they don't want to go. They don't want to face the things that we want them to face. That's why they're in front of you. And you have to make it safe enough that they're willing to venture into some pretty dark places in their life. I think of myself like a Virgil. I'm a good Jewish boy, but I still turn back to Dante's story, I need some rabbi who guides people. But I'm Virgil, and I'm taking these people through the darkest parts of their life and holding them so they feel safe, but helping them examine themselves and the dark stories that shape who they are and how we can work through and resolve and move on to paradise. The way we do it is through 5 treatment tasks structured around, this is the sequence. These are not tasks, are not sessions. They're really processes, things that we have to accomplish in order to move a family through a sequence of therapy. Task 1, I mentioned it earlier on this morning. The biggest challenge for every family therapist is getting the parents to come in the room rather than drop Johnny off. I'll drop him off at 4, I'll be back at 5. Whoa, Mom, Dad, why don't you guys come on in for a minute? Maybe we could do this together. And the whole way in which you sell that to a family is a critical skill. And for us, the core question that moves it from behavior management to a relational focused therapy is this last comment at the bottom. We do an intake, we get them all in the room, we do some history taking, we got to know if they're on meds and when they were in the hospital, good behavior, good psychosocial assessment. We tend to err a little less on getting all the detail in the first session because the families that I work with have been to 9 different therapists, inpatient treatment, emergency room. They've told this story 100 times. And if I spend the whole hour telling that story again, they go home feeling like, why are we doing this again? Can't someone just read my chart? So for us, we do enough therapy, enough assessment to get a good feel of the problem, make sure I know the critical things, get the names of the people, the psychiatrist and the individual therapists, and know the landscape. And then about 30, 40 minutes in, we say, okay, I've done enough history taking. I now want to ask, for me, the core question of my therapy. When Johnny's upstairs in his room with a bottle of pills thinking of killing himself, and Mom and Dad are downstairs watching television, why doesn't he go to you for help? Why is the attachment switch off? I'm in danger, I'm in pain. I should instinctually say, go to my parents and say, help me. And for us, that launches 10 weeks of therapy. What's getting in the way of this kid trusting you enough? We then meet alone with the adolescent to try to develop this story some more. We think about this task as 3 different parts: getting to know them, helping them understand the link between their suicide, their depression, and some of the family problems, helping them develop a more coherent narrative, helping them move from a emotional diffusion to more clear description, instead of "I don't know why I feel this way," moving into "I'm angry, I feel abandoned, I feel shame, I feel guilt," that there's an emotional landscape that these kids have no language for, and we're going to try to help them do that. And eventually this task leads to, would you talk to your parents about these problems? And I don't have enough time to convince you how good we are at convincing them, but we do. Most of our kids say, all right, I'll come and I'll speak. We meet alone with the parent, connect with them around current stressors, all the struggles in their life. Our fundamental belief, and this, everyone says in the city, in Philly, no one can work with this parent. Send him to Guy. He'll get through. Because our fundamental attachment-informed stance is, this is a parent that loves his kid and wants to be the best for this kid. There are just things getting in the way of them being the kind of parent they want to be. And we speak to their good intention, even though their method's not working. And we bond with them. We connect with them. We admire them. We validate them. We empathize with them, rather than criticize them, challenge them, try to teach them some skills. We try to connect first. We do some attachment history of their own, because a lot of these parents are bringing into therapy their own unresolved grief and disappointment about their childhood. We got a great tape. Where's Scott? Got a great tape of a mom who, wears a mask. Oh, life is great. My dad and I are close now. 45 years old. Everything, we get along really great. And the therapist starts poking. Well, what was it like when you were a child? Oh, everybody was fine. We loved each other. Or really tell me, well, my dad would get drunk and he'd beat the hell out of my sister, and my mom would kick and scream, and that would go on every weekend. And suddenly unfolds this. But even that's kind of a chatty, she's willing to tell you the details, but not re-engage in the pain, the fear that she felt. And we try to touch the pain. What were you feeling back then? What was it like? Did you go to your mom when you needed help? Oh no, I was alone. And we're trying to help parents sort of excavate their own attachment disappointments and use that as to help them take perspective about what their own child might be going through. You could be for your daughter now what your mother never was for you. It's the leverage of this session. We then bring them together. And the goal is, can we have a corrective attachment experience? Can kids come to the table and say, finally, I'm pissed off at you about chasing dad out of the house? Even though dad was abusive and an alcoholic, I blame mom for it because dad's gone and I don't see him anymore. And while that story's not accurate, it's the beginning of a conversation that allows a kid to express things and talk about things and starts to give him a little more permission to be mad at dad too. But it's hard, in a divorce case, to be mad at the absent parent, because the thread is so thin. If I get mad at him, he's never going to visit. He's already out of the house. Mom, I can get mad at because she's here. She's still committed to me. That's why the custodial parent gets the brunt of the... And my goal is that the parent will be attentive, attuned, and validate the kid's experience. So So we have this corrective attachment experience. For us, we think about it as the kind of core therapeutic task. Task 1, 2, and 3 are important, can be therapeutic in and of themselves. Theoretically, we believe this is the big enchilada. Dad coming in to Goodwill Hunting and them hashing it out. Once we have worked through some core resentments, disappointments, anger, we start to focus more on autonomy. But now the kid is, classic case we see in the beginning, kids not going to school, parents arguing with them, kids been out of school for a month. You got to go, I don't want to go, you got, this kind of power struggle. After they work through some of this resentment, the kid turns to the mom and says, can you help me re-enroll in school? I trust you more now. I feel like you listen to me better. I feel like you're on my side. I feel like I know why you're pushing me so hard. Could you help me? Could you be my secure base and help me get back to life? Our depressed, suicidal kids, if you know them, they're off the developmental track, right? They're not doing the normative things. They're not going to prom and doing summer, science programs. They're not playing guitar anymore, and they're not playing basketball. They're in their room, at best alone and isolated, at worst doing drugs, sexual risk behavior. And so we're trying to get them back on developmental track, and once we work through some of this family resentment, we find the family can be a secure base to help them with that. All right? Let's watch a short video, and then we'll go to some data. I hope this is going to work.
I'm so impressed with the two of you today in our conversation. Sophia, you've done an amazing job of being open and honest with your mom. And Lisa, I know this hasn't been easy. You've done a fantastic job of really listening to Sophia and comforting her.
In the middle of task 4.
And now that you guys are both feeling a little safer with each other, Sophia, do you have questions for your mom?
Yeah, so why did you choose to use drugs and stop taking care of me and then leave me? Why did you do that? I have no good...
Oh. This is a case, single mom raises a daughter. When the girl's about 10, the mother's father dies. It activates a kind of depressive vulnerability. Dad was really her, grandpa was really her secure base. She never got along with grandma. Mom gets pretty depressed. They move in with grandmother because mom loses her job, can't afford to live on her own. Months of some pretty severe depressive episode. Mom eventually gets a boyfriend who's a drug dealer, starts using opioids, gets pretty addicted, eventually moves in with the boyfriend and abandons the family, has a 6-month run of opioid addiction, drug use, finally gets arrested, goes to rehab for 9 months, 6 months, comes home, moves back in with grandma, wants to resume parenting, and the kid, wants nothing to do with her. Who the hell are you to think you can walk back in and be my mother after all you've done to me? And we're trying to see if we can't work through that to find some better way to live together. Whether the girl's going to forgive the mom or not is unclear, but if they don't, we have so many parents, I'm sure you do, who've been in addiction, in treatment, come home, think they can just step back in and take over again, and these kids are now 14 or 15, and they're like, you've been gone for 2 years, and you ruined my life when I was younger. Why do you think I'm going to let you be my parent again? even though underneath, part of me wants nothing more than to have you be my parent. So we try to get into that landscape. Oop.
I'm so impressed with the two of you today in our conversation. Sophia, you've done an amazing job of being open and honest with your mom. And Lisa, I know this hasn't been easy. You've done a fantastic job of really listening to Sophia and comforting her. And now that you guys are both feeling a little safer with each other, Sophia, do you have questions for your mom?
Yeah, so why did you choose to use drugs and stop taking care of me and then leave me? Why did you do that?
I have no good reason. My life was in a bad place. It wasn't going well. I was making really bad choices. I was really depressed. The drugs, they really took over. And I met Charlie, and then, all this stuff with the drugs, and he introduced me to the drugs. I don't know. I really have no good reason.
I know that's a lot to take in. What do you think about what your mom just said?
I know you were in a bad place, but you always used to say we were a team, so how could you choose Charlie over me?
I didn't choose Charlie over you, but the drugs, they were kind of filling up a hole in me. They were, I don't know, I was always felt like I was on drugs, and I was never really there for you.
Mom, I know how hard this has been for you. I think we all know that. Remember, today it's just about hearing from your daughter and focusing on her. Is that okay if we try to refocus on her?
Okay.
What do you want to say?
I love you. And I want things to go well between us, and I want us to have a relationship.
What do you think about what your mom just said?
Well, I guess I always thought that you left because you didn't love me anymore. But, maybe it was not that. Maybe it was the drugs.
I still love you. I always loved you.
But so, what's going to stop this from happening again? Sure, you're doing better now, but you could get depressed again. And then what would stop you from just doing drugs again then?
There's no guarantee I won't do drugs again. But I'm doing everything I can to stay sober. I'm going to my meetings. I'm going to therapy. I'm doing everything I can.
What do you think about what Mom said?
I guess it's okay.
It doesn't sound like you're okay with it, and you don't have to be. You can have feelings about what your mom said and the fact that there isn't a guarantee that she's going to stay sober.
Okay, yeah, I guess I'm not okay. It's scary. It's scary that you could relapse.
Well, I feel scared too.
You said, tell Sophia more about your fear.
Well, I see fear as a good thing. It really helps me with my sobriety. And I don't want to mess up your life again, and I don't want to mess up my life again. So I do see it as a good thing.
I never really thought about fear that way before.
Well, I didn't either till this happened. But I'm afraid of losing you, and I see how hurt you are.
Lisa, tell your daughter how you see your drug use and having left affecting her.
Well, I'm worried. I see you drinking, and I know you're angry all the time. And I know you're hurt.
You don't know how I feel.
You're right. I don't know how you feel. And I know I've been a bad mom. And I'm sorry. I'm sorry I've been a bad mom.
Why didn't you say anything before now?
Because I was ashamed. And I thought you needed space.
I've been waiting to talk to you about it.
And you're getting it now. Right? In this moment, you're finally talking about it. And I heard your mom apologize. Did you believe your mom?
Yeah, I did, yeah.
Tell her why you believe her.
Well, I guess it's because you're trying, you know? You're really trying, and you really seem sincere.
I really want to make things right.
Sophia, could you ever imagine being able to trust mom again?
I'm not sure. I mean, after you left, I promised myself I was not going to let you hurt me like that again. But this was a lot different from what I expected.
I'll go as slow as you want. I really want to earn your trust back again.
What are you thinking, Sophia?
I guess I can try, but I mean, I can't promise anything. When you were gone, I was getting by okay, and I have Grandma if I really need anything.
But she's not your mom. I am, and I want to be there to help you with your problems.
You're right, Lisa. And that's exactly what we're working towards. But I think we can all agree that rebuilding trust takes time. It's a process. And there's still a lot of issues to talk about and work through with each of you. So can we agree to keep working together on this?
Yes, I agree. That's why I'm here.
It's great. How about you, Sophia?
Yeah, I mean, I'll try.
Great. And we're going to continue to talk about these issues, but not today. We're getting close to the end of time, and before we wrap up, I do want to check in and see how was this for you guys to talk about all this stuff?
Simulate. Actors. We finally made some training tapes. But it's pretty good, isn't she? Oh, come on. God, give me a hard time. I thought the girl was great. But it demonstrates the heat of the center of the work. And it's only a 7-minute clip. It's not the whole, this is an hour-long, 3-session-long conversation. Where you go, how you go, what you uncover. The key thing is that you stay here. We are not running away from this topic. As much as the mom wants to get away from it, can't we change topics now? Haven't we done enough? And this girl's still seething, or there's other memories that she has that she's not letting go of until she talks about and validates. So therapy, and you make judgments about this all the time. Just stay here longer, though. Worried too many people pull out too quickly. So what is the model? What we've been talking about, we really believe that we're going to reduce ideation, depression, by improving the attachment structure. Are there other things contributing to depression? Absolutely. Could we do some CBT and some medication? Absolutely. But the mechanism we're proposing and trying to test is it's through the mediation of improving attachment, leading to decrease in ideation. I work through resentment that I have, and or I feel safer. I have a place, a touchstone place to go to, and that helps me avoid ideation. We also think that it's through these kind of conversations I learn how to regulate emotions better. I learn how to put difficult feelings into words. I feel like I can now say difficult things and not be shamed for them or discouraged about them. That this is an affective and in vivo exposure exercise, if you want to put it in that language. I'm going to help somebody talk about difficult things and find out it didn't kill them or kill someone else. Half the time kids say, I don't want to say these things to my mom. I don't want to hurt her. She's got enough on her plate. We're trying to help strengthen their emotional muscle, and we do that by an in vivo experience of emotional conflict resolution. We've done about 15 years of research on the model, some clinical trials, lots of process research studies. Our first big study was in 2010. We compared ABFT to enhanced usual care, meaning we made sure they got into treatment somewhere out in the community, variety of different options. And, you know, we had better reduction in suicide and sustained reduction compared to treatment as usual, and had some pretty good reductions in depression as well. That was our first big study. We also had good retention rates. Now, again, you know, they were referring these patients, we admit, to Children's Hospital, in Philadelphia. It's the Mecca on the hill. So patients are more likely to have some kind of institutional allegiance and they're coming to CHOP, oh, we're getting treatment at CHOP, versus community council down the street that there's a long waiting list and an ugly waiting room. And so, but retention was good. We do know that across studies, the population we work with, generally by session 4, 50% of the cases are gone. That's across. So we do feel like we're doing something to retain these difficult multi-problem families that we're working with. We also found, in contrast to studies, some people have gone back and done secondary analysis of the TAD study, the Tordia study, the TASA study. These are the big adolescent depression, suicide. Some of you probably been on them, if not the PIs in the room. I have to watch myself here, but some people did some secondary analysis to say, well, how did the kids do who have a history of abuse? And ironically, even in TADS, a big multi-site study, the way abuse was measured was not quite consistent and not well done, but emotional abuse, sexual abuse, physical abuse was sort of lumped together. But they actually found across these studies that kids with a history of abuse did not respond well to treatment. Medication plus CBT with the best therapists in the country, and these are the kids dropping out the most and responding the worst. So we looked at our data and found out, in fact, it wasn't the case in this family model, that kids, particularly with a history of sexual abuse, about 34% of the sample, responded to treatment as well as kids without a history of sexual abuse. So we're happy about that. These are not cases coming in at the reporting of sexual abuse, you wouldn't call it. What we find is, the story I always tell, the case is a girl reported when she was 12 that mom's boyfriend was molesting her. Investigation happened, boyfriend got arrested, sent to jail. Mom has resented the girl ever since. You're lying, it was never true, you've ruined our family. 3 years later, that girl ends up suicidal, coming to into hospital, and comes down to us. And the narrative in task 2 that we uncover is, I deserve this, maybe I did ruin the family, and I'm a horrible person, that's how mom feels. And the therapy focused on the residue of the relational residue of the abuse, and helping mom kind of come to terms with the impact she was having on her daughter by continuing to taunt her and tease her and humiliate her, and helping mom reorganize her thinking. So that's how we think about abuse. We've done a number of other studies, smaller projects. Anybody that works with suicidal teens, whether you know it or not, you're working with a lot of GLBTQ kids. I actually went around and asked, the big the PIs of some of the big studies, David Brent and Jonah Sarnow, my colleagues, how many kids in your sample were gay? And unfortunately, they said, that's interesting. We never measured that. We never thought about that very much. And that was the early 90s. Maybe that's past already. But we see it a lot. 30% of our kids report being gay or questioning their sexual identity. And actually, our studies suggest, not the treatment studies, kids who are questioning their sexual identity are actually more at risk for depression and suicide than kids who say, I'm gay or I'm lesbian. And part of the theory in the field about that is that these kids are in the middle ground. They don't have a community to belong to. The gay community thinks they're copping out, the straight community thinks they're gay, and these kids in their identity formation phase don't have a place to live, don't have a place to feel more accepted. And there's a number of studies to show the questioning kids are at high risk. So it's an interesting group that you should be asking about for your kids. We've done some aftercare studies, kids leaving hospital, after an attempt and using ABFT with good success in preventing more attempts. We did a great study, Gary Diamond, my colleague in Israel, did a study. It's with a emotion-focused individual therapy, the two-chair technique. Everybody remember Gestalt therapy? It's not as in fashion. You youngins probably you probably don't talk about it in your training program, but Gestalt therapy is still a strong model, very emotion-focused, process-oriented, but they used to do a two-chair technique where you'd pretend your mom's in the chair next to you, the empty chair, and you'd say everything that you never got to say to her. And sometimes you'd jump in that chair and be the mom and respond, and you'd use this two-chair, empty chair technique to do what we're trying to do. So Gary said, God, I wonder if there's a difference between the imaginal conversation, is it pretending my mom's there, versus the real conversation. My mom is there, and I'm saying these things. It's a brilliant study. He's a great colleague. And he found both treatments reduce depression and anxiety equally, as they're both good, solid interventions. But the kids, the young adults who went through ABFT, whose actual parents were there, showed a decrease in attachment anxiety and an increase in a kind of secure-based perceived feelings of their parents. So it actually changed, the imaginal conversation changed them internally, helped them work through and resolve their own things. But the ABFT conversation actually changed the relationship, which is what we're hoping. It's great. We've done some dissemination studies. We do a lot of process research studies, looking at moments of therapy, looking at alliance, looking at adherence, and as a whole. We have a website. If people are interested, you can see our big research. So we just finished our most recent large study. It's going to come out in Child Psychiatry soon. This was a randomized clinical trial. We wanted to go up, in the first, what actually got us funded is the argument is, look, we did that other big study and we did better than treatment as usual, but we know there's confounds and out in the community and what's that treatment. So now we want to control both treatments and do them both at the university to control for allegiance. And we wanted to do David Brent's, David Kolkol's non-directive supportive therapy. And the review committee said, well, you should have families involved in that treatment so you can actually control that, that the active ingredient isn't just family, the families coming in, but actually the mechanisms in your work. And, to get funded, you do what the review group says, right? Unfortunately, the treatments start to look awful lot alike and probably much more cross, or we didn't really get to test the core mechanism of a individual therapy versus a family therapy, and probably more what it looks like in the real world. More, there's minimal involvement with the parent, although with a suicidal teen. But be that as it may, it's a great study, and we also thought, we were downstairs from Edna Foa, and she says, you should do a crossover design. Like, come on, give me a, like, yeah, have the same therapist doing both treatments so you can control for alliance. You control for the quality of the therapist. They're providing both interventions, so we did that too and made. We also used community therapists. In the first study, we got such great outcome, I did half the intervention. Suzanne Levy, the experts did the treatments. That's not often the case. In this study, we said, let's not have us do the therapy till we run out of money and still have to do a few more cases. So we hired people, therapists in the community, grad students, and trained them. So, it's a good design. So we used David and David's model. We added to appease the, how am I doing time-wise? I'm running out, huh? We added a 4-session psychoed. With all the cases, we had to do safety planning. With all the cases, we offered 24-hour hotline coverage. I was talking with Cheryl King, who also, she did a big study, and she said, it's hard to do a comparative trial with suicidal kids, because you throw so much at them to take care of them, who knows what's working and what's not. You're calling them every week, you're seeing them in a crisis, you're doing family safety planning. I mean, and I think our 2 interventions increasingly looked more and more alike, increasingly had similar amounts of contact with the parents, and you'll see how that showed up. But I would say, and I'll be humbled by it, non-directive therapy works pretty damn well. And we actually, started looking at the literature. There was a meta-analysis, 53 studies of adult depression where an NST model was used as a control group. It worked about as well as everything, particularly when you controlled for investigator allegiance. If the investigator was it was their treatment, NST might have done a little worse, and we know what that can be about, and So NST is pretty potent. David Brent used it in his 97 study. It didn't work as well by certain time points, but by the end of therapy, it was working as well. Tony Spirito used it, and it beat out his CBT intervention. So there's really something powerful about a kind of Rogerian being there with these kids that has really helped us rethink some of the skills that we think about and use in our treatment. Just quickly through the study, we use pretty standard inclusion criteria. It's pretty high level of suicide ideation. We were actually funded at 3 suicide studies were funded. Mine, Anthony Spirito in Rhode Island doing a kind of CBT family model, and Marcia Linehan and Jonah Sarnow in Los Angeles and Seattle did a 2-site study of DBT. DBT and the kitchen sink, I might add. They had family involvement and group and individual and pretty intensive treatment. So we recruited 129 kids. Took us 5 years to recruit that sample. A lot of our referrals came from the emergency room. 36 came from hospitals. We work a lot with primary care settings, and they refer to us. So, we had a pretty good range of where the referrals came from. Pretty standard design. We did every 4 weeks, we did an assessment. Therapy ended at week 16, and we followed them out to a 52-week follow-up. A pretty good distribution of cases. In fact, we actually had half the sample was African American, and that's a nice addition to the literature because most studies are Caucasian kids. Pittsburgh, their samples tend to be 80% white. I know here in New York that can vary, but so we have a nice range of minorities in the sample, and they historically have not been included in clinical trials research, and so we're committed to working with that population. Good distribution of income, so it wasn't just low income, poor families. We had families across the spectrum of that. SIQ at intake, this is our primary outcome measure, 49, pretty high. That's a lot of suicidal thinking in the past month. Certainly had some kids at the high end. Some of the kids at the high end stayed at the high end and never changed. They were just, these more troubled kind of kids that you could just not penetrate easily. But 49 is high. It's also pretty similar to Marcia and Tony Spirito's. We did a panel together at APA, and our baseline characteristics look pretty similar, though Marcia had a little bit higher inclusion criteria, and all of them had to have NSSI, and I think actually it's a personality disorder she measured for. Same with depression. Average was 35 on a BDI, which again is a level nobody wants in their patients, and that's where we started. Pretty good amount of diagnostic profile. 46% had major depression in the past year. 31% had major depression at the time of intake. Lots of anxiety disorder, just really very high rates of anxiety, and we've done some papers to look at that particular profile and interesting things. 50% of our kids, you didn't have to be an attempter to get in our study. I know some of the TASA study was all attempters, that had to be. We have always sort of had a more of a prevention slant to who we were working with. So, but 50% of our kids came in with suicide attempts. 26 made more than one attempt, and we all know that one-time attempters have a more difficult profile than kids who've just had ideation, but kids with multiple attempts are way up on the spectrum of much more complicated cases, more disorder, more personality disorder, more substance use, a much more difficult case. And about half of the sample engaged in NSSI. So by no means a simple population, and it's what you get into. We did ask, we have a reasons for suicide questionnaire, and again, most of our kids reported pressures to achieve, and 80% of our kids said family relationship problems that were getting in the way. We had good retention rates. We were happy about that. 82% completed the full course of 16 weeks. We had some withdraw. Typically, and both treatments had the average of 14 sessions. We may have had multiple sessions in a week when we do these parent and kid sessions. We might see them twice a week. A lot of our kids, when they're coming out of hospital, we see them twice a week for a couple of weeks just by default. You just made an attempt. I can't wait a whole nother week to see you, so we'll do a family session on Tuesday, and then on Thursday, you got to come back. I'm going to, keep working with you until I feel like things are more stable. Our main hypothesis was change at post-treatment and using HLM. Going into the study, we assumed ABFT would do better. I'm already letting the cat out of the bag, right? But we also knew that NST worked well, and we had 2 active treatments, similar dose, same therapist. Everybody got parent education. Everybody participated, had access to suicide prevention and safety planning. And so, not surprising, both treatments did pretty equal. For us, the good news is both treatments did very well. These are significant drops in ideation. You look at the Marcia Linehan story, and this is actually looking quite similar to their drops in suicide ideation from the DBT study. We haven't seen the Spirito data yet, but both treatments did well, and there's all kinds of ways to think about that are interesting. About an effect size, if a within treatment effect size, pretty high, but when you actually do a more formal effect size analysis and compare them, it's, it's moderate, but not out of sync with other studies. So the Diamond study, when I did all the therapy, went really well. No, I'm kidding. But we still are in the spectrum of other studies where the effect sizes that they're getting on suicide outcome. And the percent of reduction in ideation was 61%. So we had a really pretty high response rate. The nice data is also we had pretty high response rates in dropping out of the clinical range on the SIQ, and actually the clinical range is 31. If you're over 31, it's clinical. If you're under 31, it's not. And some studies use that as dropping. So if I get a 28, they consider it a treatment success, and kids are doing better, which they are. But we use the more rigorous normative data that you give this to a group of high school kids, and 12 is the typical mean that it'll get. So we use that as response rate. You see at week 8, the ABFT model's having a little bigger impact in the short term, but by week 16, they're both looking pretty good. I mean, there's a little bit of a difference, but not statistically. Actually, we got significance at week 16 there. Well, 0.35. Well, we also had some really good rates on attempts. In the beginning, these kids came in with suicide of the attempters, very low rates of reattempt during our treatment. The TASA treatment study had 13% relapse by 6 weeks. We had 5% in both treatments. So again, is this a treatment factor, or is it the team that we have that just wraps around these kids and, really created a safety? I think people feel very connected to our clinic, as I'm sure you guys do sometimes too. Similar findings on depression, big reductions, similar in both treatments. Go through. Good response rates at week 12. ABFT is doing statistically better, but by week 16, they're sort of bouncing out. So there's really a trend for ABFT to be working a little faster, which is actually what David Brent sort of hung his hat on in the big 97 study, that CBT worked quicker. Kids got more relief, but by the end of treatment, all 3 of his treatments had pretty similar outcomes. We have gone back and looked at some interesting questions about moderators, starting to look. One thing we did look at is in our LGBTQ kids, how did they do? And it turns out that in NST, they didn't do as well. That group didn't respond to NST as well. So something about bringing kids into a family intervention. Sometimes we're talking about them being gay, sometimes we're not, but it seemed like the opportunity to have that be available in conversation was helpful to kids. We've also done some interesting latent class modeling. Since the whole sample is kind of responding similarly, we could combine the sample, and we actually found we had 3 different groups. Low-level kids with good response, moderate-level kids with good response, and 15% of the sample, high-level kids, poor response. Now, this is pretty typical in all studies. In the TAD study, I think 43% had a good response by post-treatment. So there, if you're getting 70% response rates and your overall sample, you're pretty happy with that. But there are always these difficult kids, and what do we know about these kids? Most of them were on medication, probably suggesting they'd been in treatment longer, more complicated kids. Low on optimism, often not living at home, more association with peers, and more likely to have major depression. We did a mediation model to see if, this is pretty fancy, right? And in fact found out that, the more we could change family cohesion by mid-treatment, the better the depression scores were. So it's a nice sort of validation that at least Rob DeRubis at Penn, in Paul Kurtz-Christoph have written some papers that sometimes when treatments both are working, it's not that regression to the mean, though it could be, but there may be different mechanisms within these treatments that are leading to those changes, and that's worth exploring. And what we're finding is that our proposed mechanism of improving family relationships, when we can do that, we can lead to better outcomes. Just 2 more slides here. So what's the interpretation? We're certainly humbled, and regression to the mean may explain this 8-year, $3 million project. It would be a sad to return to that. But on the other hand, both treatments worked well, did as well as many other big studies where both CBT plus medication plus additional treatments were provided. Did it as a once-a-week outpatient therapy, did it with community therapists. So in some ways, this model, we're sort of arguing it might be easier to do NST or ABFT in a typical outpatient setting, whereas the problem we're all going to have with Marcia's study is who's got enough time and resources to do 8 hours a week of therapy with the DBT model. As wonderful as it is, we love it, but it may be more appropriate in a day treatment or inpatient unit and may not fit a kind of typical outpatient model. Future directions. We're trying to think maybe we should build a more multi-component I know I got a lot of DBT people here. I love the work. All of our kids get DBT, believe me. It's just, how do you pay for it? How do you pay for the model she just tested? You can still do what we do. We're starting to think about a multi-component model. How do we juice up the power? Add medication. We'd like to do a parent education piece that could get at some of these things. We're involved with some creative arts therapy people and talking about dance therapy and music therapy, songwriting therapy as an augmentation to some of the work. It just is engaging. We're also very interested in dissemination models. We're involved, as many people are, in sort of how much of this can we put into a web-based learning system so that people could get it more easily and more quickly. We're trying to build a program that we could import into graduate school programs so that it could be taught more often at the graduate level. And as I said, we're working with some residential facilities to try to see if we could get closer to the attempt episode and do that. Thank you very much for coming. I guess we're going to do a little question for those that
We have some time for just
can stay.
questions.
Hi, I was just thinking in terms of what you're trying to add to the program, if maybe you thought about the Stanley Brown safety planning intervention, which was developed within TASA when we were doing that, which is first crisis contact, because you can't invest in all these long DBT and CBT. That's been remarkably effective. It might be a nice...
Yeah, we actually do safety planning. Both treatments got that, and we use the safety plan throughout. So that's already in the
Already baked in
packet.
there.
Yeah, you can't not. You got a suicidal kid, you gotta,
Yeah.
ethically, you have to do it. So, and we think it has added strength. We do a kind of family version of it. So we really have the parent involved in creating it and sustaining it. We really sort of use it as an enactment of parental caregiving, gives the parent something concrete and positive to do. And so I totally agree. It's a great intervention. Anybody else?
That was great. I wanted to ask about the girls and the boys. Because from what I remembered, 80% of the sample were girls. I remember when Marcia presented sort of the same question. And that, I guess it was about a year ago when I heard Cheryl King, who's been trying to focus on boys.
Yeah.
And so I just wanted to bring it up with regard to, how do you think this is more
Girl-oriented, yeah. No, I have, In terms of the data, gender didn't differentiate, didn't moderate outcomes, so we definitely have looked at that question. In terms of the clinical phenomena, I think there are some variations. I think the emotion focus, the attachment focus tends to resonate more with a female orientation, just from a social stereotype, if nothing else. The boys that we did have, if you want to do suicide research with boys, I think David Brent said it once, if you want to do suicide research with girls, you go to primary care. You want to do it to boys, you go to juvenile justice, because that's where the troubled boys are, and plenty of suicide there. So, and I would, if we look back on our cases, I think the boys were much more overly regulated, much more shut down, certainly involved in some deviant peer activity. So it was a harder quest. It's not indicative of all of them, but one of our cases with a boy, the first 3 sessions, he'd be in the room with us, and the only way he would talk was through texting. So the whole session was done on text, across from each other. And, it was only after that so it just took a lot longer to get access to his sort of inner world. And so, but that's my quick response. Do you have your own experience with that or thoughts about it, or?
No, I agree that
Yeah.
it's quite a challenge to get to the boys, and they do have more substance problems, and they have more, as you say, acting out problems and
Yeah.
problems with the loss. So it's just a group that they're hard to engage.
Yeah. It's actually interesting. It's one of the reasons I've turned to this music therapy, because I originally thought, actually a dance therapy person I work with, and I thought, boy, I bet this really works. Maybe she's trying to do a dissertation. I said, you should do it with girls first, because you would think girls are going to resonate with dance, and, the boys are, and she said, oh, it's the opposite. And she's in an inner city population where a lot of multicultural kids, but she says the boys love it. They just get into it. There's pride in being a good dancer. And so it might be a mechanism that we're going to use to try to connect with the inner life of boys.
So I have a question.
Yeah.
Because I'm interested in the psychology of clothes. Do you find that the hat helps?
Oh, definitely.
How do you use it? Seriously, do you?
Gives me a lot more pizzazz.
We haven't had a lecturer here in all the years I've ever been in PI who's worn a hat during the lecture. So you certainly got my attention for that alone. Not that I really like.
Who cares about the data?
No, I love the data, but seriously, do you wear the hat when you
do.
work with the kids and everything? And what does it mean?
I don't often wear it in therapy, though we just made 20 of these training tapes, and I wore my hat in the training tapes. It's become my signature thing, My dermatologist said to me one day, you have, cancerous growth on your head. If I ever see you in town without a hat on, I'm gonna, read you the riot act. And I said, all right, I kind of like hats anyway. And now I go out of the house without them, and I feel naked. So I wear them all the time, and I wear them I go to conferences, and people, is that guy? Guy, where's your hat? I don't know who. So it has become a little bit of my signature presentation.
This seems like a basic question, but it's a question I struggle with all the time, which is when should we refer someone to family therapy? When should we do individual therapy with parents present? All of that kind of stuff. It's something I always struggle with.
Yeah. In our clinic, everything starts with family. We just go in. I want the family stuff settled out. If I would love to do a crossover design study where they come, they get family and they get CBT, and then they cross over and they sort of an ordering design study. Because I think kids will be more receptive to CBT when the chaos at home is quieter. You can do all my good skill building, and then he goes home and mom's still yelling at him, and it's just hard to hang on to and implement. So that's my little pet NIH proposal. But so for us, it's always from the family, starts with the family. I see what I have to do, and then I transition into individual if that feels right. There are plenty of cases I see a kid alone, and Parents can't come in, parents are too, we got a case now, mom is too difficult. We have tried, really a kind of borderline anger. Anything you say, it's an attack on her. She's really smart, so she just runs circles around me. I can't keep up with her paranoid logic. So initially, we said, she was complaining that the dad's not doing enough. She's a stay-at-home mom, and I do all the work. And so we said, you're right. What, Mom, why don't you stay home and Dad bring the girl to therapy? And, it was partly to, I'll admit, to get the mom out of the room. It was also, she's right. There's work I could do with daughter and dad. There's bonding to be repaired that could be helpful that I knew I wasn't going to make with the mom. But I say that cautiously because we don't give up on parents easily. And too many of us, have one bad session or one bad phone call and say, oh, forget this, too difficult. And we go a couple of rounds and we meet alone with them and we do what we can to believe in them and touch their heart and see them as a good parent. And in fact, the case that this videotape is built on was a substance abusing mom actively using DHS, said, don't even bother bringing her in. You're never, just work with the grandma who the girl's living with. And Suzanne, mom would come in, disorganized, skittish, and we did some great work with him. So don't give up on him easy, but be self-preserving at the same time. And you're smiling like you know. I mean, there's a lot more we could say about decision rules, and that's a quick answer. Happy to talk about more.
Thank